This talk is going to be about conscientious objection and conflicts of interest in medicine, which are two different topics, two different issues. At least they've been treated as two different kinds of problems in medical ethics so far. But the whole point of this paper is to try to bridge the gap between these two things and to argue that in the end, so they more or less are the same kind of problem in medical ethics, or better, conscientious objection is a type of conflict of interest in medicine, or should be conceptualized as a conflict of interest and treated and regulated accordingly. So this is based on a paper I wrote with Julian Saulescu. And because we both worked a bit on conscientious objection in the past, and we were asked to write something about conflict of interest, and we thought that it would be a good idea to try to see how these two topics are related. So some of the things I will say will be basically a follow-up on what Steve talked about last week about conscientious objection, but I will try to take a sort of different angle on the problem. So it might be useful to start with a few hypothetical scenarios. Well, not so hypothetical, because these things are very likely to happen in healthcare delivery. So suppose there are two people who have a viral infection and they want antibiotics. So they go to the doctor, they ask for antibiotics, but they have a viral infection, so they don't need antibiotics. But that's quite a common practice to overprescribe antibiotics, even when they are not necessary. So doctors do that. That's very bad because it contributes to antibiotic resistance, which is a big public health emergency these days. So these two doctors have two different stories. So one doctor normally receives gifts from pharmaceutical companies. This is quite a common practice, especially in the US. And there is evidence that gifts from pharmaceutical companies are associated with a greater likelihood of prescribing certain drugs. So the first doctor received gifts from a pharmaceutical company. The second doctor has quite a tragic personal story. So his mother died of a resistant infection recently. So he's very aware of this problem of antibiotic resistance. And what happens is that the first doctor prescribed antibiotics. So the one who receives gifts from pharmaceutical companies does prescribe the antibiotics, even if they are unnecessary. And the second doctor refuses. So we don't know whether the background influenced the choice, but that's all the information we have. So there are two different stories, two different kinds of. So the first doctor have a clear financial interest because the pharmaceutical company pays him for prescribing. So that's the first scenario. So the second scenario is a vaccination case. So there are three parents who are hesitant, so are not sure whether to vaccinate their male children, against HPV. So HPV is normally subsidized for females, but not for male, because it increases the risk of some types of cancer, particularly in women, also in men, but to a smaller extent. So normally is given and is only subsidized for women. But recently there has been a sort of change in many countries and some policies. So now it has started to be subsidized also for male children. But doctors are still less likely to recommend the HPV vaccine to males than to females. Now, again, what we know is that the first doctor received gifts from pharmaceutical companies, so the company that produces the HPV vaccine. And so this doctor does prescribe and does recommend and prescribe the vaccine and administer the vaccine to the child. Second doctor is like a feminist doctor. She has certain ethical views, and she thinks that only females should receive a free HPV vaccine. So she doesn't recommend the vaccine. She doesn't administer the vaccine. The third doctor is also a feminist, so same ethical views, but she has a different approach. She thinks that it's good to give the HPV vaccine also to male children, because if you only give it to females, you sort of place all the burden of responsibility for the transmission of the disease only to women. That's quite a common approach as far as I know among feminists about vaccination. So she does administer the vaccine. So again, there are different backgrounds, different stories about these doctors, and they make decisions. We don't know to what extent their background and the financial interest affected their decision, but that's all the information we have. So, and it's interesting that two doctors with the same ethical views, the feminist doctor, so one does prescribe the antibiotic, the vaccine, and the other doesn't. Third scenario, so that's abortion. So there are two women who need and want an abortion, which is legal. That's where the country where they live. So they have two different doctors. The first doctor is a Catholic. Second doctor is a feminist. So they have different ethical views, different backgrounds. And the first doctor, the Catholic, refuses to provide the abortion. The second doctor, the feminist, so feminist believes that women have a right to terminate a pregnancy whenever they want, for any reason. So she eagerly offers the service. So she provides the abortion. Now, what's going on in all these cases is that all these doctors have some personal motives or values or goals that can affect influence their professional practice. We don't know whether they do, but they can. So sometimes some cases it's reasonable to assume that their goals and motives and values affect their practice. And all these goals and values are not really part of the goals and values of the medical profession. They can be consistent with, say, if you're a feminist doctor and you provide an abortion to a woman who asks for it and who needs it. So that's consistent with good medical practice because that's what doctors should do. But it's not that being feminist in itself part of the value of the profession. So some values are consistent with the value of the profession. Some values are not. Some values affect the practice, some don't. Now, the question, the problem that we wanted to address in this paper is whether these doctors should be prevented from acting on their personal motives, and if there is any significant difference between, like, among all these cases that I presented. So there are different kinds of motives, values, and goals of the doctors based on their backgrounds and on their stories. So some of these are regulated, some are not in medical guidelines. So the question is, should all these cases be regulated or be treated differently? So the mainstream approach in healthcare ethics and also in biomedical ethics more in general is that, so for example, of all the cases I've discussed so far, so only the case of the doctor who prescribed antibiotics because the doctor who received gifts from pharmaceutical companies and prescribes the unnecessary antibiotics, and perhaps the case of the doctor who received gifts from pharmaceutical companies and administered the vaccine. So in this case of financial interest, so the mainstream approach is that only these cases are ethically problematic and need to be regulated. So if you have a look at the guidelines of the main, like the National Institute of Health or the General Medical Council in the UK, so they only address financial conflicts of interest. They only consider them as ethically problematic. But all the other cases, like if a doctor is a feminist and their being feminist affects their practice, if a doctor is a Catholic and their being Catholic affects their practice, generally the general approach is that these things don't need to be limited or regulated. Actually, some interests and moral beliefs, like especially religious ones, are actually supported, not just tolerated, but supported by so-called conscious clauses in legislation, so in the form of conscientious objection. There are some exceptions. So some scholars and some institutions, some organizations like the Institute of Medicine, they do consider non-financial conflicts as problematic. But even when they do, so the tendency is to think that this kind of interests either should not be regulated or cannot effectively be regulated. So we shouldn't be worried about those anyway. So we should only focus on financial conflicts of interest. So the point of the paper is to try to argue that ethically impermissible conflicts of interest in healthcare are not only financial in nature, and the same regulatory approach that we use to address financial conflicts of interest should be extended to at least some non-financial conflicts of interest. So the point is that all those cases can be ethically problematic, and it doesn't matter whether the interest that motivate the doctor to do something is financial or non-financial in nature. What matters is whether these interests conflict or are consistent with professionalism and good medical practice. Now, the way we try to argue for this is to reflect a bit on the notions that are involved in this debate. So what does it mean to have an interest? What does it mean to have a conflict of interest? And what does it mean to have an ethically problematic conflict of interest? Because not all conflicts of interest are problematic, of course. Depends on, well, how we get there. Anyway, so interest normally is one of those concepts that are normally not really defined in the literature. So it's normally taken to be one of these basic concepts. We all know what we mean when we talk about interests. But there is some philosophical work on it, of course. So generally, philosophers, so these are the kinds of definition they offer. So according to Joel Feinberg, so one interest consists of all those things in which one has a stake. And a similar definition is the one I put here. So to have an interest in something is to have a stake in it. So to stand, to lose, or gain, depending on what happens. Yeah, so these are very broad definitions. The Royal Australasian College of Physicians defines an interest in the context of healthcare delivery, more specifically, as a value, goal, or obligation associated with a social relationship or practice. Now, if these are interests, it seems clear that both financial interests, like gifts from pharmaceutical companies, and non-financial interests, like moral beliefs, for example, fit this definition. So they are all interests that people have. And with regard to healthcare delivery, we can distinguish two kinds of interests, like individual interests, like financial or non-financial, moral beliefs, gifts, any kind of motivation, like desire for status, recognition, all these things. These are all interests, according to this definition, and are individual interests. And then there are, of course, professional interests. Now, professional interests are what someone should do. So what kind of things should be, one should have a stake in as a member of a profession, a professional body. So professional interests are things like a concern for patients' health, but also other things like a minimum standard of fairness toward patients, toward one's colleagues, towards the healthcare system. So receiving a salary from a healthcare system means that that's true not just for the healthcare profession, for any profession. That's part of the basic work ethic. So you receive a salary, you do something. Same salary means you should do the same things as other people, other colleagues. So these are all interests that belong to the profession. So you can have an interest as a professional, you can have an interest as an individual, and the problem is that these things can conflict with each other. So about conflicts, so one thing to notice is that, of course, not all personal interests that affect one's professional practice generate conflicts of interest. So you can have personal interests, and these personal interests might influence the way you behave in your profession, but there is no conflict there. Like if you're a feminist, for example, and you provide abortion, that's not a conflict of interest because the two values are actually support each other. So because abortion is part of good medical practice. I'm taking for granted that abortion is part of good medical practice because that's what many guidelines say. The American Medical Association clearly says, literally, that abortion is consistent with good medical practice. So that's the standard of the profession. You might disagree with that, but that's what the profession is at the moment. So Also interesting, so the very same interests might or might not give rise to conflicts. So if you think of the examples I gave at the beginning, so payments from gifts from pharmaceutical companies, they gave rise to a conflict of interest in the antibiotic scenario. So the doctor prescribes unnecessary antibiotics because they receive gifts from pharmaceutical companies. So the doctor has a personal interest and there is a conflict with the professional requirements. The vaccination scenario as well. In the vaccination scenario, so the doctor receives payments from a pharmaceutical company that produces the vaccine, but providing vaccination is good. So it's part of good medical practice. So there is a personal interest that affects the practice, but there is no conflict. Feminist views the same, like in the case of abortion and vaccination. So in the case of abortion, as I said, there is no conflict because being a feminist is consistent with the value of medicine, so providing an abortion. But in the case of vaccination, that can create problems. So certain feminists believe that only females should be given the HPV vaccine. Well, that might be a conflict because it's good to vaccinate male children as well. So maybe that's a conflict, maybe. And also the other thing is that sources of conflicts can be very different. There are many of those. So I mentioned money so far and moral beliefs, but things like prestige, reputation, respect and praise for one's group, these are all personal motives that one might have and that might affect one's professional conduct in ways that can generate conflicts. Not necessarily, again. So suppose that, I care a lot about my reputation. So I want to win the prize for the best doctor of the hospital. I don't know, something like that. That's a personal interest I have, and that can affect my practice. It probably does. But maybe there is no conflict. That's a good thing, because in order to win the prize for the best doctor and acquire prestige and reputation, I need to be a good professional. So there is no conflict. But there might be conflicts if maybe I could just pretend to do some things and I don't do them, and that might create conflicts. I don't know. Anyway, the point is that there are different motives and goals that people have, and then can or might not create conflicts, depends on circumstances. So the other important thing is that, so I've talked a bit about conflicts, about interests and conflicts of interest. Not all conflicts of interest are ethically problematic, of course. We probably all have conflicts of interests in our profession, because sometimes we have to do things that for work that we don't like, sometimes think we don't agree with, or not very pleasant. That's true for any profession, and including the healthcare profession. So conflicts are only ethically impermissible conflicts of interest when people are not justified, so in violating other people's conflicts. So I put this long quote from Feinberg, so I'm not going to read it, but the idea is that sometimes conflicts of interest are not ethically permissible, but you need to have a justification for when they are permissible and they are not. And that can be very difficult to determine in society at large. So often we have these conflicts between different principles, these very vague principles like freedom of conscience, right to self-determination, right to private property. And it's very difficult to balance these principles, these rights in general. So when we have a conflict of interest in society in general, we might have really no clue about which interest should prevail. For example, I don't know, if there are people like pro-life groups often go to organize to protest outside abortion clinics, for example, and they say, we have this religious view, so we should be free to demonstrate, to voice our opinions. So we have an interest in these things, in voicing our opinion. But then women who go to the abortion clinic to have an abortion, they also have an interest in like having an abortion in the best conditions possible, so without having people outside shouting about God or these things. So, and one might say, okay, it's difficult to tell in this case. Well, it's not difficult to me, but some people say it's difficult to tell in this case which kind of interest should prevail. But when we talk about specific sectors within society, and one example of a specific sector is profession. So normally there are clear guidelines, clear principles, clear rules to decide how these vague principles, for example, freedom of conscience, should be applied, and what kind of interest should prevail. For example, healthcare. So contemporary medicine, at least in Western countries, is basically based on the standard 4 principle: autonomy, patient autonomy, beneficence, non-maleficence, and justice. Some justice and fairness. Plus, there are some basic professional requirements that, as I said before, apply to any profession, like doing what you're paid for. So you receive a salary to do certain things, you have to do that. Respecting your colleagues and not treat them unfairly. So you shouldn't overburden your colleagues because you don't want to do certain things, because you are paid the same. Now, this approach, so with regard to healthcare, this approach based on the fourth principles is a bit, so it does have its own critics. So it's not, I'm not just taking it for granted, but normally no one really questions these 4 principles in themselves. So problems are often raised as to whether this can work as a system. So if we have a criterion to decide which principles should prevail when they conflict with one another, whether this approach is comprehensive enough, or whether we should include other principles like solidarity, for example, these things. So, but no one really questions things like patient autonomy and beneficence and non-maleficence and fairness are important values of the profession. Maybe they are not enough, but certainly we should take those for granted, at least in contemporary Western medicine. Now, even if it's difficult to regulate conflicts of interest in society, within a specific profession like healthcare, we do have clear guidelines. And what's important to notice for the purpose of this paper is that both financial and non-financial interest can violate this principle of healthcare. So it doesn't really matter whether you do or don't do something in your profession because you receive money from a pharmaceutical company or because you have certain moral views. So the point is still that you are not, so the point is that both these things can affect your practice as a professional. So as I said before, the problem is not so much, so what exactly is the ethical problem here? So the problem is not so much that you have interests, personal interests that can conflict with the professional obligations, but the problem is when you allow these interests to affect your behavior. So for example, so if a doctor receives gifts from a pharmaceutical company, that might not be unethical per se, if it doesn't affect one's practice. But it becomes ethically problematic when these things affects one's practice in a way that contradicts the principle and the value of the profession of medicine in this case. However, for practical reasons, some people think that, so even if this distinction in principle can be traced, so even if we consider not all conflicts of interest translate in actual behavior, but in practice, you might just want to prevent, to regulate all conflicts of interest, just to avoid the risk that they could affect a doctor's behavior. So the regulation of conflicts of interest needs to be not only ethically justified, but also feasible and sufficiently easy to implement. So one might say, okay, so let's get rid of all possible sources of conflicts of interest, or at least financial conflicts of interest, that what people have focused so far. So let's say prevent doctors from receiving gifts from, but at least large gifts from pharmaceutical companies, for example. So that's the standard approach. Now, just to summarize a bit where we are so far in the paper. So nothing of what I said so far suggests that only financial interests generate conflicts of interest, or that only financial conflicts of interest are ethically problematic, that is, they translate in actual behavior that is unprofessional. So as I said before, for example, a financial interest in prescribing the HPV vaccine to a male child does not generate a conflict of interest. But a non-financial interest, such as a religious opposition to abortion, can generate a conflict of interest, according to the definition of interest and of conflicts of interest that I've provided. And if you look at the definitions of conflicts of interests that are normally provided in the literature in healthcare, you can see that they easily apply to both kinds of conflicts, like financial and non-financial. So here I put a few definitions. So Brennan, for example, and co-authors, they define conflicts of interest as, so conflicts of interest occur when physicians have motives or are in situations for which reasonable observers could conclude that the moral requirements of the physician roles are or will be compromised. This applies equally well to financial and non-financial interests. Or the Institute of Medicine in the US, they say that a conflict of interest is a set of circumstances that creates a risk that professional judgment or actions regarding a primary interest will be unduly influenced by a secondary interest. And according to Brody and Erde, so this is among the first papers that were written about conflicts of interest. So according to them, an interest that gives rise to a conflict of interest in healthcare is one that would tempt a person of normal human psychology to neglect the patient's or public's interest in favor of the physicians or third parties. Again, nothing here suggests that we are only talking about. So all these authors, they mean to refer to financial conflicts of interest, but these definitions, if there is a problem with conflicts of interest, according to these definitions, then the same problem would arise in case of non-financial conflicts of interest. Now, the paper is meant to focus on one particular type of non-financial conflict of interest, which is conscientious objection in healthcare. So the claim is that conscientious objection in healthcare can be conceptualized as a form of conflict of interest, and more precisely as an ethically impermissible type of non-financial conflict of interest. Ethically impermissible because it's not just an interest, and it's not just a belief. So conscientious objection is a behavior. So it's okay for a doctor to be a Catholic. It's not okay when the doctor's being Catholic affects the behavior. That's when it becomes ethically impermissible. And because it's an ethically impermissible type of conflict of interest, it should be regulated in the same way as we should regulate ethically impermissible financial conflict of interest, other things being equal. Okay, so you have these two kinds of conflicts. They affect a doctor's practice. They should be regulated in the same way, other things being equal. I just thought this. Sorry, I'm a bit lost. Okay. Now, conscientious objection. Okay, so Steve talked a lot about this last week. I won't go too much into details, but so generally speaking, conscientious objection in healthcare is the refusal by healthcare personnel to perform certain professional activities, often including the referral, so referring a patient to another doctor, because they conflict with their own personal, moral, or religious views. So conscientious objection represents a conflict of interest, an ethically problematic conflict of interest. First of all, because conscientious belief, so one's conscience, does represent an interest, according to the definition I provided before. So moral or religious views that motivate conscientious objection are interests, according to the notion of interest that we presented before. They trigger motivations and goals that are relevant to and can affect one's professional practice. There are many reasons why doctors put forward conscientious objection, so they want to preserve their moral integrity, or often they want to preserve their reputation in the eye of one's group. So if you work in a hospital where everybody is a conscientious objector, which is often the case in Italy in the case of abortion, then you might want to be a conscientious objector as well, because your standing in the hierarchy would be affected otherwise. So this motivation to act based on one's conscience is very strong, and often it will take a large sum of money to give practitioners an equally strong motivation. So if you want to compare financial and non-financial conflicts of interest, you have to consider the motivation that is provided by one's religious views is often very, very strong. So there have been many cases that also went to the European Court of Human Rights, so of women who died because they were denied an abortion in Poland some years ago, of children that were born with severe disabilities because doctors refused to provide abortions for religious reasons. So this means that doctors' commitments to their religious views is very, very strong. And clearly this represent interests in the sense I discussed before. So they provide goals and motivations that are very strong, that can affect one's practice. And this kind of interest can conflict, in the case of conscientious objection, both with patient's best interests. So if a woman wants an abortion, you don't provide the abortion, you are going against the woman's best interest, if the woman needs and wants the abortion. They create conflicts with the professional obligation to do one's fair share in one's profession. And they can also create other kinds of conflicts with other requirements. For example, there is a basic requirement of non-discrimination to treat all patients equally. Some forms of conscientious objection, which are not recognized in the law now, but some people would want to push for those, raise these kind of issues. For example, Muslim doctors, many of them would want to refuse to do things like inspecting patients of the opposite sex or inspecting patients intoxicated by alcohol. They appeal to their conscience, their religion, the same way as a doctor who's a Catholic appeals to their conscience to claim that they don't want to perform abortion. There is no difference. It's the same. It's exactly the same kind of objection, which is an objection based on religion. We tend to think that people tend to think that the one about abortion is permissible and this one is not, but I don't see any reason because it's still a religion. So the implication of this is that allowing any non-financial conflict of interest to interfere with one's professional obligations is no different from an ethical point of view to allowing a financial conflict of interest, say gifts from pharmaceutical companies, to interfere with one's professional obligations, with the fulfillment of one's professional obligation. And this applies to conscientious objection as well. So a non-financial conflict of interest, like conscientious objection, should be regulated in the same way as ethically impermissible financial conflicts of interest are. As I said before, other things being equal, so I said, yeah, these two kinds of conflicts, they should be regulated in the same way, unless you think there is some ethically relevant difference between the two. Now, and this is the problematic point, of course. So you might say, yeah, but things are not equal, so there are ethically relevant differences between the two. And I think people would likely come up with these three types of differences between financial and non-financial conflicts of interest to justify the claim that only financial conflict of interest should be regulated and considered ethically problematic. I don't know why the slides have three number ones, so it should be 1, 2, 3. So some people say that even if this is all true in principle, in practice, non-financial conflicts of interest are difficult to detect because you don't know what moral views people have, so it's difficult. And whereas financial conflicts of interest are objective, are measurable, you can find out. Or one might say that in the case of a non-financial conflicts of interest, especially if there are moral views or religious views, there are some requirements of privacy, whereby you can't really force people to disclose their interests. So you cannot really regulate them because you shouldn't ask people whether what their religious views are or things like that. Whereas financial conflicts of interest are not covered by this privacy requirement. Or some people, so this is the third difference, some people will say that it will be a form of discrimination to prohibit certain non-financial conflicts of interest, especially religious, those based on religious or moral views, in the same way as we prevent financial conflicts of interest, because some people say that non-financial conflicts of interest, certain non-financial conflicts of interest, like moral views or religious views, are really constitutive of one's personal identity. So you can't really ask people to give up their, say, moral or religious commitments. And you cannot exclude people on this basis from jobs, because that would be a form of discrimination. Whereas money, gifts from pharmaceutical companies, you can more easily, so it's less problematic to require people to give up these kind of things. So not to take money, that's not discriminatory. But if you don't give someone a job, or if you prevent someone from upholding their religious views in order to get a job, some might say that's a form of discrimination. Now, some of these are actual differences between the two kinds of conflicts of interest. So our claim is that they don't provide strong enough reasons for distinguishing between the two types of interests. So we still think that financial and non-financial conflicts of interest could, at least in some cases, be treated in the same way for the following reasons. So first of all, it is true that even if in principle conflicts of interest are ethically equivalent regardless of whether they are financial or non-financial, all things considered, so those three differences might provide reasons to treat them and to regulate them differently. There can be ethical reasons like discrimination, or practical reasons like it will be difficult to detect when someone has a non-financial conflict of interest in some cases. But in the case of conscientious objection specifically, these three differences do not provide reasons to treat the two kinds of conflicts differently. So these three differences between the two types of conflicts do not apply to conscientious objection for the following reasons. So first of all, it's true that it is often difficult to detect non-financial conflicts of interest. And this, in general, weighs in favor of constraining or regulating only financial conflicts of interest because they're measurable, they're objective. However, in the case of conscientious objection, this issue doesn't really arise, because the whole point of conscientious objection is that doctors are claiming that their conscience, their moral views are preventing them from fulfilling certain professional requirements. So you can easily detect conscientious objection because that's part of the practice. So in order to be able to say not to perform an abortion, a doctor needs to declare that they have moral views that go against abortion. So this practical problem doesn't arise at all. So we know when doctors have a conscientious objection. Same applies to privacy, so privacy concerns. So you might say that people shouldn't be forced to disclose their moral beliefs, their religious beliefs, because there are privacy rights about this. But again, conscientious objection is based on the assumption that people disclose that they have a conscientious objection. So you say, I'm a Catholic, so I cannot perform an abortion. So even in this case, this kind of concern doesn't apply. So if the problem is a forced disclosure, then the solution is not to have policies that presuppose such disclosure. So, but conscientious objection does presuppose the disclosure. So this does apply. And the third concern is this thing about unfair discrimination. So this is a bit more complicated, because people would say, yes, but if someone is a Catholic, you can't really prevent this person from entering the medical profession just because he's a Catholic. You should allow this person to be a doctor, to be or any kind of healthcare professional, but then exempt this person from doing certain things because of their religious views. Otherwise, that's a form of discrimination. Now, well, I don't have time, but so this is based on a mistake, I think. And the mistake is to think that these things like freedom of conscience, freedom of thought, freedom of religion, which are also in, I think, Article 7 of the UN Declaration of Human Rights. So the mistake is to think that these things are really coextensive with freedom to act according to one's thoughts and conscience and religion. And that if it is a form of discrimination to treat people differently based on their conscience, thought, and religion, then it is a form of discrimination also to treat people differently on the basis of their behavior, which is based on conscience, thought, and religion. But that's a mistake, because conscience, thought, and religion, of course, are not the same as behaviors. We can't do whatever we want, whatever our conscience tells us, or whatever our religion tells us. So these are two separate fields. And often, so it would be good if these two things went like hand in hand. So it would be good to be able to respect both conscience and behavior. But that, again, that doesn't apply to profession. So in professional settings, people are generally, that's true for any profession, are generally not granted freedom to stick to their moral or religious beliefs in a way that contravenes the professional obligations. You can think of all sorts of examples with other professions where people just cannot do what their conscience tells them to do, but that's not a form of discrimination. So this example that I brought up the discussion last week after Steve's talk. So if I'm a vegetarian and I'm a waiter, I can't refuse to serve meat to the customers just because my deep religious beliefs or moral beliefs tell me that it's wrong to kill animals. I have to do that. And if the owner of the restaurant tells you either you serve meat or you go find another job, that seems fair to me. Because that's what happens. That's what we commonly accept. And the same should apply to healthcare professions. So it's not a form of discrimination to require certain behaviors. It will be a form of discrimination to say, okay, you are a Catholic, so I'm not going to hire you because of your religious views. That's a form of discrimination because you're not protecting this person's conscience and thought and religion. But behavior is not the same as conscience. So they are two different things. And in professional settings, they are normally treated differently. And no one would say that that's an unfair treatment. Also because we live in a society where there are many ways of protecting religious and moral freedom. You can take political action, choose a different profession, promote societal change. So there are all these things that, for example, a Catholic doctor could do if they want to change the standard of the profession. Just what they should not do, based on the discussion so far, is just let their conscience prevail at the bedside. So when they are with the patient, that's not the place where your conscience should prevail, because that's a conflict of interest, in the same way as it would be a conflict of interest for a doctor who receives gifts from a pharmaceutical company and refuses to provide certain services, or does provide certain unnecessary services or drugs like antibiotics. So there are two kinds of solutions that are normally proposed for conflicts of interest, like financial conflicts of interest. One is a disclosure requirement. So some people think that doctors should be required to disclose any conflicts of interest they have that can reasonably be expected to conflict with professional obligations. This is to promote transparency, and so to make behaviors informed by personal interest that conflict with the professional requirements less likely to occur. But that's not applicable to conscientious objection, really, because conscientious objection goes in the exact opposite direction. So in that case, disclosure is used exactly to ensure that ethically impermissible non-financial conflicts of interest occur. So you disclose your conflict, and then you are allowed to stick to your conscience. So that kind of solution doesn't apply to conscientious objection. And the other solution is the prohibition of financial gifts or financial conflicts of interest overall. So the idea here is that doctors should not have interests, financial interests that can affect their profession at all. It doesn't matter whether they disclose these interests or not. They just shouldn't have these kinds of interests. But if you allow conscientious objection, then that's precisely what you are doing. So you're allowing personal interest to compromise one's professional behavior. So if we think that conflicts of interest should be prohibited in the case of financial interests, there is no reason to think that conscientious objection should be treated differently. So the same prohibition should be applied to interest of conscience. Yeah, so these are the conclusions. Basically, that's what I already said. Conscientious objection in healthcare is a form of conflict of interest. There is no reason to treat this kind of conflicts of interest differently from the way we treat financial conflicts of interest. There is no ethical justification. There is no practical justification. So in the same way as doctors' conflicts of interest are regulated or even prevented in the case of financial interests, they should be prevented or regulated also in the case of conscientious objection, which basically means that there should be no conscientious objection in medicine. But that's something I've argued for in other papers in different ways. So this is, I think, a new way of arguing for the same conclusion. But I don't know what you think. Yeah, so that's it. Thank you. Sorry, it was a bit messed up, but yeah, thanks.